We are moving on to the next presentation with topic Therapeutic Use of Contact Lens. Dr. Daddi Fadel, who is D. Optom, Fellow of Scleral Lens Education Society and Fellow of American Academy of Optometry. With immense pleasure, I would like to welcome Dr. Daddi Fadel and request you to proceed with your presentation. Over to you, ma'am.
Okay, thank you. Hello to everyone. So, thanks to the organizer for the kind invite. It's a pleasure to lecture in this meeting. So, I will be talking about therapeutic use of scleral lenses as agreed with the organizers. So there are several indications for scleral lenses. A major group that can benefit from scleral lenses are ocular surface diseases. It's the precorneal fluid reservoir that ensures continuous hydration of the ocular surface, alleviating symptoms and reducing clinical signs induced by the ocular surface diseases. They have important advantages for dry eye, secondary to different conditions, or persistent epithelial defect, inflammatory conditions, limbal stem deficiency, and ocular cicatricial pemphigoid. Scleral lenses can be a great treatment for option for vascularized limbal keratitis as well. The key here is to avoid tight-fitting limbal compression and suction. The lens also needs to be well aligned on the conjunctiva. In this case, there is an increase in neovascularization and edema along the host graft junction in a post-keratoplasty cornea secondary to FACS dystrophy. Edema and neovascularization disappeared after adding a smart channel in the haptic at 3 and 9 o'clock to prevent and minimize the lens suction and facilitate the fluid exchange. The channels may be directly ordered to the manufacturers, or they can be handmade, as in this case. Scleral lenses are also indicated in ptosis. This is a case of 20-year-old woman with a bilateral ptosis for 17 years, secondary to chronic progressive external ophthalmoplegia. A large diameter scleral lens with increased vault was fitted, allowing a greater aperture of the eyelids. Severe ptosis may also be treated, including a step to hold the upper eyelid and allowing a major aperture of the eyelids. This is a case of a persistent corneal epithelial defect following penetrating keratoplasty. Scleral lenses were fitted to support the ocular surface and to facilitate the healing process. Vigamox was added to the lens reservoir prior to each application to minimize the risk of microbial keratitis. The resolution of the condition occurred following 7 days of lens wear. After rehabilitation, wearing schedule was modified to daily wear and lubricants ointment was added for use at night. The outcome, it was that no recurrence of the persistent epithelial defect at 8-month follow-up. This case is very interesting because it showed that it's possible to corneal opacities to resolve with daily wearing of scleral lenses without the aid of other treatments. The key here is again to avoid tight-fitting limbal compression and fit a well-aligned lens on the conjunctiva. Scleral lenses in dry eye are indicated as the protect the ocular surface. When fitting scleral lenses, it's very important to check the presence of lid wiper epitheliopathy, since this condition is considered a nearly sign of dry eye, which can compromise the result of lens fitting. In these cases, the lens should be fitted as large as possible to protect as much as possible the exposed surface, ocular surface areas. Whatability is an important issue when fitting scleral lenses in patients having ocular surface diseases. The lens surface will now be a compromise as the ocular surface was before fitting scleral lenses. Whatability affects vision, comfort, and wearing time. It may increase the chair time and cost to find a remedy to this condition. Patients with the predisposition to experience poor lens whatability are those with blepharitis, demodex, and dry eyes, Also, a patient with exposure keratopathy, ptosis, nerve palsy, and eyelid repair may experience whatability issues. There are also different exterior causes as well as poor hygiene, cosmetics products, and hand soap types. We have different management strategy for whatability issues. We know that mucins and lipids are attracted to the hydrophobic gas permeable skull lens materials, forming a deposit and resulting in poor whatability. So selecting a material with low wetting angle, and this often means a lower decay, can help improving lens wetability and reduce the hydrophobic areas that attract deposit. It's important to aggressively treat the patient's ocular surface disease, and despite changing the lens design and material, the surface of the lens may remain compromised if the condition isn't properly managed. Patient education is crucial. Hygiene and hand washing are imperative. Research has shown that post-lens tear debris consists of a high concentration of lipids, and surprisingly, lens surface and tear reservoir clouding issues are common in patients with ocular surface diseases. So you need to check the soap used. You need to avoid deodorant, scented, or moisturizing liquid soaps. You have to recommend clear hand soaps, mild basic hand soaps, those specific for contact lenses or those indicated for the treatment of acne. Do not apply makeup or oil-based moisturizer to the eyelids. Oils can spread along the skin and contaminate the tear film. Use makeups that are not oil-based. Isopropanol-based exercise daily cleaners are especially good at removing oils and makeup from soft and rigid contact lenses. Lid hygiene is crucial for managing lens with poor wetability. There are several products for lid hygiene. Care solutions should be checked as well, and you need to revise them. Digital rub and rinse is necessary for good comfort and vision. Inadequate surface cleaning may cause irregular hydrophobic surfaces that may create a debris attachment cycle. Do not use Basel Advance. If the patient is using Simplus, try Clear Care, and vice versa. Try traditional GP contact lens disinfection solutions are thick and viscous, which may result in chamfer degrees and cause fogging on lens surfaces. So instruct patients who use such solution to rinse the inside bowl of the lens with saline prior to application. Cleaning with the Progent also is an option once a week or biweekly, depending on the ocular surface conditions and the lens wetability and deposits. This solution can loosen and remove surface protein deposit, bacteria, and fungus after only 30 minutes soak without manual rubbing. You can suggest the use of lubrication with preservative-free artificial tears over the lens throughout the day. You can suggest to remove the lens, clean it, and reapply it, or polish the lens, but careful because this would remove surface treatments. What patients can do while wearing the lenses is to wipe the anterior surface of the skull lens when it's applied on the eye with a moistened cotton swab or a skull lens plunger. You have to place a drop of lubricant in the eye and rub the surface of the skull lens with the device when it's applied on the eye. You can prescribe Hydropack treatment. This is a video of a lens without Hydropack showing poor wetability. In this video, we can see the lens with Hydropack treatment drastically improving surface wetability. Debris or midday fogging is also an issue when fitting ocular surface diseases. So managing the atopy and ocular surface diseases before fitting skull lenses is important. You can also reduce wearing time in some cases when debris persists. We have three types of debris that may occur. Mucous debris appearing as small and white particles, diluted milk fogging associated, milky fogging is associated with atopic diseases and ocular surface diseases. And you may have also all droplet debris. So what you can do, reduce a limbal vault. Here we can see the OCT picture shows debris formation with high limbal clearance, and reducing the limbal clearance allowed to clear the fluid reservoir from debris. A balanced electrolyte solution can reduce this phenomenon. You need to instruct your patient to avoid taking breaks during the day to remove, clean, and fill the lens with fresh preservatives-free solution, because this will increase the formation of debris. Instead, you can tell your patient to hold the preservative-free saline on the edge of the lens and squeeze the solution into the reservoir. In this video, fluorescein has been used to show how this technique allows for complete reservoir renewal. So in conclusion, scleral lenses are indicated in different conditions to protect and heal the ocular surface. In these cases, the lens should be as large as possible, well aligned on the conjunctiva, avoiding limbal compression and lens suction. In these cases, the lens is more subject to poor whatability and deposits. Different management strategies are available. Fogging also is an issue, so you need to review the lens design or care solution. Thank you.
Thank you so much.